So in India, most of the families, if you see, we do not have specialized centers for taking care of patients in need of care. It's most of the time the families who take care. And I think when you, like I, for example, left my job to take care of my child because she needed to go to Haji Ali for physiotherapy and occupational therapy. So it was not expected that my husband would leave his job and sit at home. It was expected I had to do it, and I wanted to do it also. So I left my job, I left my social circle, I left my uh, friends at work, and so many other things.
Hi.
Hi, I'm Mahesh Menon.
And I'm Smriti Khanna.
Welcome to another episode of our podcast Living Well. We have with us today Dr. Priyadarshini Deo. She works in Kokilaben Dhirubhai Ambani Hospital in Andheri. And we'll be talking today on palliative care. We'd like to know a little about you. So I think I'll ask Smriti to start with the questions.
So, Priyadarshini, is there a nickname? Is Priya?
I am comfortable with Priya. Is yeah, as Priya.
Can you tell us a little bit about? Mahesh has told me that you actually started as a doctor and then you moved into the social medicine sphere. You started counseling. So, can you tell us a little about what made you want to
About
do
my
that?
education. First and foremost, I'm Dr. Priyadarshini Deo, and I'm so thankful that you guys have me here to speak about palliative care. Uh, well, I was so fascinated by the human mind that I studied psychology. And then when I studied psychology, I realized that I was fascinated with the human physiology and, other things about it. So I did my MBBS in AM. And then I went into the social sphere. I was fascinated working with people. I wanted to work in the community and with people directly. So that's how I entered social work. I went on to do my master's in medical and psychiatric social work. And when I was studying there, I was fascinated with research. So I went on to study, I did my PhD in psychology. So that's how the journey had started. And here I am today working in the field of palliative care.
It's a very interesting career trajectory. So, if you were to compare, say, medicine, when we look at preventive and social medicine, which deals with community health, like doctors don't deal just with patients alone, we also deal with communities and planning healthcare strategies, throughout. And that's not very interesting for many doctors because we'd like to just focus on treating and curing and getting done with it. How was the transition for you from that part to what you do now, to the social work that you're doing?
So I wanted to, as I said, I wanted to work with people. That was my focus. And when I was doing my medical and psychiatric social work training, I had seen so many, I had visited Tata Memorial at that time as a part of our fieldwork uh, project. And I was there for about 3-4 days. I was placed there. That's when, and my specialization was medical and psychiatric social work. So I was studying about medical social work as well as about psychiatric social work. So when I visited TMH, and that time we were very raw, young students. So I met some social workers and I understood so much about working with people and working with people with serious medical illnesses. And that's how I realized that this is something I want to do in life. Of course, I did not directly work with people with serious physical illnesses. I first worked with people with serious mental illnesses. And that was also like palliative care because these are people with schizophrenia and major mental illnesses. So we had a lot of life skills programs for them, and we had to educate them a lot about psychopharmacology and the therapies and things like that. Family education was very important. There was a lot of caregiver distress over there also. And then I moved on to working with cancer patients. So it was a kind of, I have had exposure to all kinds of areas of the healthcare sector, and that's how I'm here.
So I think that, like, you kept saying that, or you were saying that doctors like a quick fix kind of approach,
Yes,
like
yeah.
get in there, fix it, move out,
Yeah,
sort of a
it's
thing.
more curative.
It's more curative, but I think that there is definitely this kind of underlying continuous kind of support that families need, that patients need, that communities need, and that's what you were saying, is that palliative care also talks to that kind of continuous baseline layer of support, and working with patients with mental illnesses is, or working with people with mental illnesses is part of that also, because they are, mental illness is something wherein you do need a lot of background continuous work. It's not a quick fix, it's not a one and done kind of situation. um, can you tell me about something that kind of just charged your introduction or just made you want to get into palliative care?
Especially the part where you mentioned you had some exposure to Tata Memorial Hospital. Now, many of us work there, and it's like a fountainhead of learning when it comes to cancer and oncology, and by default, palliative care. So, what were there any experiences there that kind of triggered this interest, or how was it?
At that time, there were not many experiences because I was just there for 2, 3 days and I was just absorbing all the things because I had not seen so much of pain and suffering, to be frankly, and I was very young. So it hit me. And I said, there is a part of a section of society which also goes through so much of trauma. And it was very difficult in the beginning. I mean, I literally was crying for 2 days when I was there, and it was like for me itself, I was traumatized because I had nobody in the family with cancer, or I had not heard about cancer or serious health problems. It was an exposure which was like life altering for me. And then when I was working with mentally ill patients, I also have a daughter who is physically challenged. She has cerebral palsy. So I was a caregiver, and I was her sole caregiver because my husband was always on transfers. I think I understood caregiver burden at that time. I was going through depression. I was going through a lot of trauma, stress, uncertainty as to how would I manage her? How would she be able to take care of herself in the future? There were so many dilemmas at that time. And at the same time, I was working with people with mental illnesses. And we had patients who were mentally ill who also had cancers. So that was something, and it was an overall, so much gamut of emotions from all sides. And sometimes it's so difficult for, to counsel a patient with a serious mental illness like schizophrenia, and to make her understand that you need a surgery or you need to go through chemotherapy with the range of emotions that the person was going through. It was even more difficult and challenging.
So tough to do it
Yeah,
with
and
somebody who is able to understand and process emotions. It becomes such a challenge for them, and it becomes,
Yeah, and for the caregivers also, because for example, if the patient is going through a breast cancer surgery or chemo, sometimes their medicines are altered, and they are so dependent on the medicines, at that time, and that can shoot off a range of problems. So these were some of the things that hit me a lot, and that's how I made my shift. So when I got the opportunity at Kokilaben Hospital to work with oncology patients, I immediately said that this is something I want to explore, and that's how I stuck to the job.
it was very interesting how you described that there's what we describe as that burden of illnesses and the burden of suffering, and that's a domain that is usually not visible because all of that is left outside when
the hospital.
outside the hospital when the person walks into the hospital and comes in. When we look at it from that curative mindset, so it's people like you who are there in the background, who are there providing, as you rightly said, that baseline, that complete network around.
Yeah,
That's what
also
we
it's
do in
not like a
palliative care.
hospital. When you're working with an NGO, and when you're working with NGOs where whatever the illness could be, we also work with communities.
Correct.
I mean, we do home visits, we visit them in the house, we meet the families, we meet the neighbors, because that's the support that the community offers to these kind of people. And most of my patients, when I was working with mentally ill, were most of them were referred from BMC hospitals, so they were not very affording kind of patients. They were that kind of a population. So that was a different kind of an atmosphere, and that's exactly what I wanted to do always.
I think all of us here have done home visits for patients, and it's I remember when I first did one of my first few home visits, I was so struck by the stark difference that I know I'm seeing. One of my first home visits was a 30-year-old boy who had cancer.
I
And
like it how you said 30-year-old boy, but yeah, please
30 year
continue.
old man who had cancer. One of my first home visits was a 30-year-old man who had cancer. And I remember just being so struck and overwhelmed by a small room with so many family members around him, and nothing is sterile like how it is in the hospital. Like in the hospital everything is controlled. It's there are white sheets, and there is a nurse next to you, and there is somebody telling you what's happening to him, and you have one family member who is maybe wanting to ask questions. But here it's just such a different environment that it struck me that this is how it must be for the patient, for this man. If he were to come into the hospital where everybody around him is unknown, his environment is completely different, he is scared because of his illness. And I think that it's something that everybody should do. Like everybody who is in the medical community should do home visits at least
Yes.
once in a while, just
I
to
guess.
know
Yeah,
how it feels like.
I agree with you in the sense a lot of times when we do home visits, uh, we don't realize that there is also this element of life that goes on, because the disease doesn't stop when the person has walked out of the room. So when we use the phrase continuity of care to just ensure that it reaches all over, all across, and to including the homes. So whenever people ask me whether they need to be at home or they need to be in the hospital, and we tell them about their preferences, so we often tell them that the home has some qualities that your hospital won't have, and your
Yeah.
hospital has some qualities your home doesn't have.
Yeah.
So you need to have the right approach, and very tailor made for that particular person. And it is
Yeah.
true, I agree that anyone who enters the field of medicine must go out there into the community and understand that this is the life stories that are coming to our clinics, and they are bringing it and sitting next to us and giving us that privilege to interact for that moment and see how we can influence that. So that's what's remarkably interesting about what you said. You used a term, caregiver distress. Now there'll be people listening who won't know what caregiver distress means. So could you say something about caregiver distress?
So in India, most of the families, if you see, we do not have specialized centers for taking care of patients in need of care. It's most of the time the families who take care. And I think when you, like I, for example, left my job to take care of my child because she needed to go to Haji Ali for physiotherapy and occupational therapy. So it was not expected that my husband would leave his job and sit at home. It was expected I had to do it, and I wanted to do it also. So I left my job, I left my social circle, I left my uh, friends at work, and so many other things. And I had to be focused only taking care of her, because at that time that was the need for the hour. And that's what I see with most of the our patients. I mean, there is a wife, there is a husband, there is a daughter, sister, son taking care of the person. It could be just bringing the person to the hospital. It could be sitting there in the daycare the whole day for the chemotherapy. It could be paying the bills. It could be so many things that the caregiver is doing. And at so many times it happens that the caregivers, at the peak of the need, they are so involved into the whole thing that they do not take care of themselves. Okay, they don't even take a power nap or a break, because it is expected, and it is something that we socially think it's very normal that you have to do it. There's nothing to cry about it. It's not like abroad that you have systems where you have somebody coming on a particular day to relieve you, and if the person would do that, then they would go into guilt also. So at some point, I think this leads to a lot of distress in the
So it's like a
person.
social structure, and then there's the
Yes.
emotions of guilt and that responsibility. It's understood that there will be members.
And there could be financial
Limitations
also,
probably.
limitations also to have somebody taking care.
Even geographic for that matter, because some of the people who we interact with, they mention that it's difficult to keep someone at home because you're already
the
living
space
in
is small.
in a
Yeah.
city. Sometimes
Yeah.
your space restrictions are there, and you can't have additional members in the family. So
Yes.
that's an interesting point that
But
you had raised here.
it's quite amazing that you took. I would imagine that you took something out of your own personal experience as a caregiver, and then brought it to your job, to your work. I mean, we always say personal and professional. You cannot. You should not mix. But I don't think that ever happens. Like personal always mingles with professional. So some of your own values, some of your own belief systems always kind of go into what you do as a profession. What don't you think?
Yeah, because the personal experience that I went through, it was it was a learning for me, and I put it into practice when I'm seeing my patients and caregivers. I understand what they go through. So it was, for example, for her, it was almost 10 years of rigorous physiotherapy and, so many things. Then she had LD, so all those testings. So it went on and on and on. So even with our patients, those who are having cancer or other illnesses, it could be dialysis, it could be neuro degenerative illnesses, it could be anything. They need long treatment, it could be stroke. And, it goes on and on for a while. So one person is stuck. They wouldn't call it stuck, but then that person is actually stuck. Yeah, and I can empathize with them. I can empathize with the patient and with the caregiver, because I have seen both sides of the coin. And I also empathize with people who cannot do the caregiving actively, because my husband had to work. Unfortunately, his job was such that he had to work. So I cannot complain about it. It was not a choice we made. It was something that just happened and we went with the flow.
Yeah, that's an interesting point you raised, that we assume that all right, the woman is supposed to take care, and there is sometimes someone, the man who wants to take care but he can't. Because of the social role. So
yeah.
You said another point that we made right now when we were discussing. You said about serious illnesses, and you spoke not about oncology, because we started with your experiences in Tata Memorial, how it shaped your future. I have another question leading to that later. But the first point I want to ask you is, you mentioned different conditions like chronic kidney diseases, you mentioned neurological illnesses. A lot of times people assume that palliative care is only dealing with oncology or cancer. So, what is your take on that with what we know now about it?
No, I think it is with any serious illnesses which goes on for a while, and we don't know how much the person would recover and be functional 100%. And even they may at some point also, but something that goes on for a long time, things like dialysis and all that, yes. So that would be also considered as palliative care.
Yes, because I remember while we were working, I remember her visiting the dialysis units,
Okay.
and and people who undergo dialysis. What are the challenges that, say, the caregivers face, and the people who undergo dialysis? What are the challenges that you have seen from the social and psychosocial point of view?
So dialysis, I did have a few patients coming to me for counseling. So one is, I think the main one of my patients, I remember, she was a writer. She was a writer for films, and she had to come for dialysis at least 3 to 4 times in a week. So it would be the whole day, almost practically the whole day. Though she would live very close by, but she was living with her mother. She was single, living with her mother. Her mother was also alone, so she had a caretaker who would bring her, and she would just sit and weep and weep and weep, because she says, one is, along with the dialysis, I have so many other she also had she had RCC of the kidney. So that was one of the reasons she went into dialysis also. And so many things she would talk about, and she would say, I feel so, I don't have any role to play as such. And that was one challenge that she faced, that I am not a daughter anymore, I'm not a, a lover anymore, I'm not a writer anymore. So many dimensions that I saw in her. And she finally wrote a book, and then she invited me to, the opening of the book. And it was so unfortunate that before the opening she passed away. So that was very touching. But of course, her mom was there, and I went to meet, and it was such an such an emotional kind of an event, because the mother said, no, she wanted it, so we will have the event.
Made it happen.
Yes,
You made it happen.
yes, so that was.
It's something that she had been working on, and
Yeah.
she managed to complete it. It's always it's a win.
It's a win. That's what I told the mother. That I said that at least it was her dream. She fulfilled her wish, and she's there somewhere looking, feeling proud about it. And I think that encouragement was needed for her, because when she said, I don't have any role to play, I said, this is something you're doing, and I think this is something you should look forward to.
But I think that that's something that I have found quite interesting when I looked at when I entered into palliative care. It's almost like looking at things through another lens. So it is a bit about accepting reality and accepting the fact that the things that you were able to do before, you are not able to. But also this looking at things from a different lens, from a different perspective. So how you were able to convince her that, or how you were able to make her understand that, okay, you may not be able to fulfill these roles, but this is something that is there, that you are able to do in your life. And that's amazing.
So
That's
we
wonderful.
just measure the impact of any illness on the different domains of our personalities, our existence. And I like that part where she couldn't be a daughter, she's not a lover, she's not, someone who does everything that she does. Instead, her role is just that sickness role of that particular person getting dialysis. And so I feel even for the caregivers, isn't it important that she managed to achieve she did something that she wanted to, and which highlighted one aspect of her life, and she was able to bring it, because at the end of it, it's the caregivers who have to pick up the pieces and move on with their lives as well. So when we talk about palliative care for the family, palliative care for the society as such, so are there any instances where you've faced such win stories, in palliative medicine, or do you see them, or is it just dark and gloomy? Because people will think you're working with palliative care, you're working with distress, it's always going to be stressful. Is there any other dimension to the work that you do?
I'll first talk about the challenges. Challenges I face with children in palliative care. I mean, it's very tough, really, working with children, working with parents. That part is little, for me, it's little dark and gloomy even now. It's difficult, because it is heart-wrenching to see your mother, say that, do you realize what it is to lose your child? It's very tough to answer that question. And I had a patient recently, and the mother said, my son has made a bucket list and he's dying. I said, so you will fulfill the bucket list without him? She asked. I said, yes, without him, we will see to it that you fulfill your bucket list. And over a period of time, she got convinced, and she's fulfilling his bucket list. Wins, if you say, I had a patient, I won't name him. He was diagnosed with CA esophagus, and he underwent treatment. And at some point, we broke the bad news to him that the disease is not getting any better. And he said that, fine, I do not want any more treatment. And he continued to live for over 2 years after that. And he was like, I am not scared of dying. I don't want to go through that pain of treatment. When I know that I'm not going to get cured, I think even he has handled him for his pain and other things. So that was, I'm still in touch with the family. And, we talk to each other at times. I keep asking about how his daughter is progressing. He of course, died during COVID. He also came and told me, I want to take the COVID vaccine. Somebody would say that, why do you need a vaccine? But that was so important for him.
I wrote to Roger Federer. I wrote an email because he was a huge tennis fan.
The same person.
Yes. So I wrote an email. I just Googled Roger Federer. I wrote an email. And of course, I didn't hear a reply, but I wrote an email that there's someone who wants an autograph, So I did that.
Yeah. So his face is always smiling, when you think about him, I can see him smiling.
So we see champions, who kind of
Yes.
smile through the disease process, and they're very inspiring. And we like, it's a privilege to be treating
Yes.
all of them, all of them. So it's a privilege. Uh, you were talking about the caregiver distress that you had experienced when you were a trainee, when you went to the Tata Memorial Hospital and you saw this flood of people there. What do you think has changed in your experience from then and now in the field that you're doing? Is there, what are the major changes that you would like to highlight? Is it, would you still say that okay, India is just where it is uh, now, where it was then? You know, is the same thing, or things have changed for the better, for the worse, whatever you feel?
I feel things have changed over a period of time. Now we have more specialized professionals with who deal with palliative care. There's better pain management today, and it's nice to educate patients that you don't have to live with pain, because that's one question that patients ask. I hope I won't have pain. I think that's a very important point, and which I think at some point was, I think when I was a student, it was not that much possible. Like we have blocks and all that today. Many of the things what we have today are not there. Also, we professionals, over the years, we've learned so much that I think I was emotional at that point. Today, I'm not emotional. I'm more sensitive, and I deal with. I'm more communicative. I listen more. I listen to everything the person says, and I register it before even giving an answer. It's so important to do these things. So yes, India has definitely
And again, an interesting part before you ask your next question is that you worked in a space which was more in the public domain. Now you work in a corporate setup. What's the difference that you say? Because you mentioned that you would see the BMC, there's the Bombay municipality, which deals with those who may not be able to afford, say, private health care at the present costs, so unless they're insured or so on, and which they may not be. And in the corporate sector, you do see a lot of people who spend out of pocket, who come in with, who may pay for services. What is the difference that you see in terms of the caregiver distress in these two groups? Is there any difference, or is human suffering the same everywhere? Or
overall human suffering is the same, but definitely when we talk of the patients in the lower sector, they are more open to the challenges, and they understand. That's what my experience has been. They accept things more easily because they already are living in circumstances which are challenging. So it's very easy for them to accept uh, diseases or whatever new challenge comes up. And I mean, even when I had a patient with schizophrenia, he would take his ECT and come to the daycare. So I would tell him, today you've taken your ECT, you should go home. And they still come, they are okay with it. अभी ये अपने जो corporate patients who come are like, can I have wheat grass? Can I have this? Can I, there's too much of, can I have this kind of a fruit? Then will I feel better with this? So there's a lot more of, I think, ऊपर ऊपर का बहुत ज़्यादा चल रहा है अभी. Not with everybody, but of course.
Sometime if you are having a conversation with a patient who you would think that okay, he may not understand if I'm trying to explain the illness to them, they might just get it. And they might ask questions, and you will be struck by, okay, how fast have they assimilated, they understood. We talk about this in communication, where you have to wait for the information to sink in, wait for emotion to come out, and only then go forward, so that you are able to, so that the person in front of you is able to process and then plan what needs to be done. And that time of taking in the information, getting the emotional reaction to it, and then moving forward to the next thing about, okay, treatment or whatever it is just different for different people. And that's what I think I like so much about palliative care, is that this is something that I felt, that palliative care is truly personalized care. Because if you think about personalized medicine as we have learned it in our MBBS, it is genetic. It is like, I will check your DNA and I will give you medicines according to your DNA. But before that, every person's mind is so different. Their way to understand, to assimilate, to cope with things is so different that that's where you first need to personalize, right?
Yeah, and
And you
also
will take into account all the socioeconomics and
correct.
the challenges that they have already had in their life.
And
Uh,
a good therapist cannot be judgmental about all that either.
yeah,
Because it's
exactly,
okay to be having
exactly.
your own
It's
personal
fine. It's fine to
journey.
take your time
Yes,
with
yes.
understanding, with planning, with deciding. It's fine to do all that.
So that you talk about the genetic factors in personalized medicine and the extrinsic factors. So at the end of it, it's a sum total of everything that you're looking
Yeah,
at in
yeah,
palliative.
yeah.
So it's and it is truly personalized then. So a quick question for both of you now, because my challenge when working with Dr. Priyadarshini with adult patients is when I would refer them to her, they would say, "Who's she?" So I said, "She's the counselor. She's going to take you through this because I can see that there is distress, and she will help you through this process through your treatment journey." And they would say, "Doctor, हमको कैंसर हम पागल नहीं है." There is stigma sometimes of mental illness, which is even worse than that of the stigma of having a serious illness like cancer. In adults, I would find that for a large portion in your career, you've worked closely with pediatric palliative. And what has been your experience with this referral pattern to pediatric counselors? Has it been the same?
So that's actually, there is a fundamental difference in how the health systems operate here. In a government health system, if the doctor under whom you are admitted refers you to someone, they will come and see you. You are not really bound to say yes or no to see them. You are at least bound to have that first consultation, and then you can say yes or no. There is no monetary thing involved in that. So many a times people want to not spend more money on counseling or on home services, or those
The
services.
additional,
They
what is,
think about
yeah.
them as allied or additional extra services. So the setup I worked in was a government setup, and I think that also how the team is structured makes sense, makes a difference. So we
Okay.
would move together as a team. We would be a doctor, a nurse, a counselor. All of us would move together as a team, and that I have found even in a paid healthcare service, even in a corporate model, that is something that works the best. If you say that, oh, we are part of a team together, like she and I will both be taking care of you together, it just it lessens the burden for them. They don't think too much about it.
Correct.
And then it becomes smoother.
So we did that. We would round together. For
Yeah.
palliative care rounds were together, and we would see most patients together. Is it still the same? Is the stigma that you experience with adult patient referrals, is it still the same, or has it changed?
No, patients do come. Now I think now more than the patient, the family members want that the patient undergo counseling, because I think the younger generation, which is there right now, they all are aware. Of course, they're all aware now that there is, my father is going through depression also. My father is anxious about his treatment, is feels sad sometimes. So they request the medical oncologist or the surgeon to please give a referral to the counselor. Do you have a counselor? We would like to. It could be simple things that the lady is having hair fall now, and then she's feeling sad about it. So the children bring the parents if they are there. So I get a lot of referrals, self referrals now, which I think is very good. And sometimes the patients themselves also ask for a referral themselves.
So do you think that there's a change in the way the older generation looked at quality of life and the present generation looks at quality of life? Is there a change?
Interesting.
Yes, I think.
Because I would imagine talking about counseling to someone senior in my family, and if I would talk to them about counseling, I know the resistance that will be there, and I know how
Yeah.
children talk about counseling and therapy nowadays. And
It's almost become cool now
it
to,
is
Cool, yes,
to go to
it's cool. It's
therapy.
I
good
would
to
say
go to
it's not-
therapy.
It's not
And
uncool.
it's not
Uncool,
uncool to
yes,
be to go to
yes,
therapy,
yes.
and that has definitely helped the public image of therapy and counseling.
So I think it's good that people want to come for therapy because they do want good quality of life, and they do want to deal with their emotions. They do want help, and they don't feel ashamed of asking for help,
Exactly. All this
and
is
they're
part
open
of
to even
it,
go to a psychiatrist if referred, which is I think very good.
which is a big step.
Which is a very big step.
It didn't happen a
No.
few years ago, up until a few years ago. But
So
I
again,
also want to hear stories of, I mean, because you are at KDH, I know that
I was
Mahesh
there,
was
we were
at
working together,
KDH.
yeah.
I want to hear stories about what would happen when you two were on rounds together.
So we've had great experiences in the sense we'd go talk to. So for me, the advantage was talking about pain and getting rid of the pain part, and then we would introduce this concept where we have a nurse who would be seeing the pain issues, and she would also be working with us, and we would talk. The nurse and madam would be there, so all of us would be going. It's just three of us, but all of us would be going in together and talking to the person who's going through these issues, and then we'd start knowing the family, and then she would talk to them, and after I had left the room she'd be there for some more time. She'd be spending time with the family, and then she'll come back. So that's how we came to know. And the interesting part for me, I can't remember any anecdote or any story from then, but the interesting parts would be like, she would, after a point, she would call me and say, so I think his pain medicines need to be changed a little more. And I'm like, you stick in your like, that's my job. But no, that's the beauty of working in a team. So she
Oh,
would
yeah.
pick it up, and she would say his pain medicines. And I'll tell you something it sounds very silly, but many times people who miss their medications and they do miss out their prescriptions, and they need to get those medicines from a particular hospital, and if there is a gap of a few days, they come to us and they are saying they are in a lot of pain, and we ask them, what happened? Has the medicine stopped working? So no, we just ran out of medicines, and we didn't take it for the last 3 or 4 days that we're supposed to be taking it. It seems so simple, but you can imagine 3 or 4 days every
Of pain
few
medicine
weeks
gone.
of a person being in pain, and you add that over a 1 year treatment journey. That's about a month of suffering, which is unnecessary. So having a team helped that, because as doctors we write the medicines and go away. And now she's talking to them, and then they say, "Oh, we need." This is also a point of distress. How will we get it? And then we try and arrange things for them,
Yeah.
help them out. So the
Yeah.
social dimension that she mentioned was extremely.
So it's very
important.
comfortable for them to just message me, or text me or call
And
me.
she's approachable, and they call and they're in distress and they talk about it. So different domains would be covered by this.
Yeah.
So
So this is also about like setting systems in place. And sometimes you just need a little bit of additional help to set a system in place. Say that, okay, if on Friday the medicine is getting over, let's go on Wednesday and buy it. But just making that and somebody telling it to you when you are sick,
yeah,
going through a bad time, you are unable to think for yourself. It just
look on
adds
both
that.
sides of the road before crossing. It's a look on both sides. I mean, if you drive in Mumbai, you'll see it's not followed. We're looking.
We're looking for the road.
Inside the car, we're looking at all sides of the road. But those who are crossing. So it's something that needs to go out there, and that's another word that she had used. She said education. So how much of counseling is education, and how much of it is listening to the patient?
First, listening to what they're saying, extract as much history as possible, then some psychoanalysis, and then educate. Because then it makes sense that, okay, this could be the reason, that could be the reason. And once you are aware, that brings about insight. And when there's insight, there is more acceptance.
Nice.
And this is over one meeting or over multiple.
Sometimes over one, sometimes multiple, depends. But most of the times I take a lot of time with patients. Rather, patients take a lot of time with me because give them enough time. There's no hurry.
How much time is enough time in a
Normally
consultation?
slots I take about an hour.
So 1 hour of
Yes,
1 hour of
yes,
discussion.
1 hour of discussion at least.
Yeah.
Because see, it starts with a small thing. It could be just that I'm not getting sleep. But then when you dig into it, you know what is actually happening. There are so many dimensions to not getting sleep.
Yeah, yeah, yeah. Very
And
cool.
how many people who come to visit you would actually need to take medications and visit a psychiatrist for medications, or is it part of? Have you managed to get it as a part of a psycho-oncology process, or how is it?
Not all our patients need psychiatric help, but these days I've seen anxiety related issues are predominantly there. Yeah, because I think they're missing work and things, and a lot of they're worried about what will happen to the family. So all the roles that they play, and since we live in all small houses, all those things, I think anxiety is one thing which and it has to be managed, especially with treatment. It has to be managed. It cannot be just dealt with talk therapy. So once the symptoms of anxiety are reduced, then they are more open to
Yeah.
And one
discussions.
person's role affects everybody.
Yeah, so most of our patients is secondary to medical condition. Depression and anxiety secondary to medical condition.
Because
Correct.
the standard community treatment for stressors and reactive depression and anxiety is इतना क्या टेंशन लेने का ज़्यादा सोचो मत इसलिए तो don't think too much or you think too much.
So we have that kind of population also. And there are others who will say that they may be having addictions, they may be smoking and drinking and all that, and they are taking treatment, but they would not want to take medication because that could be addictive.
Oh, that's very
That
That
is
is
that is very
true.
interesting.
That's very
So I asked them, who's prescribed you the cigarette and the alcohol? So a psychiatrist who's worked his ass off for so many years.
So I think the next startup idea should be antidepressant cigarettes. We have something like that. That's really a good idea to take that.
Great.
Or the husband comes and says, don't give depression medicines to her, it'll be addictive. And do you smoke and drink? Yes, every day. So are you addicted or she would be addicted?
Oh, this is cool.
So,
Great.
any questions before we wrap up this special episode today? Because first of all, thanks for bringing your life stories and sharing it with us, and
Yeah,
putting it
thank
in
you.
front
Really.
of the background that you come in from, that the space, the work that you do, and the extra edge, that superpower that it gives you. That you've done something, you've succeeded at it, you've done well, and you really, I must say that you have done very well. I've seen
Thank you
that.
so much.
I know the children are doing very well, and that's what. So if you see all of that and how you're working, people are very happy whenever they interact, and it's great. Thanks for bringing that point up.
Yeah.
And
Hmm.
a few nice things that we get to understand about this domain in palliative medicine, which is not just medicine, not just giving medicines and surgeries or radiation. It's also about the person, the family, their home, their surroundings.
So for me, counseling in palliative care is not a career, it's more a way of life.
Wow.
Wow.
As long
Wow.
as long as the hospital doesn't say, since it's a way of life for you,
No,
you
it
got to be
doesn't
paying
mean it
us
doesn't
for
have
it.
to be in the hospital. I've had relatives who have been in palliative care. I've had my in-laws, I have my brother-in-law, I had my aunt. So I feel so blessed that I could help them because I was in the field. So it was, yeah, it definitely helps.
Yeah,
Any
no
thoughts?
questions from me, but just gratitude. Thank you
Thank you
so
so
much
much.
for coming, and like, there's so much of yourself that you shared, of your own life that you shared, of all your experiences in the house, in the hospital, everywhere, and very grateful.
Thank you so much. Thanks for having me.
Guys, we did it.
First episode
We did
done.